Hello and welcome. I'm Elisa Hernandez, a librarian at Stanford Health Library. Thank you for joining us for our talk, Tips for Managing Chronic Conditions. It's my pleasure to introduce our speaker, Dr. Randall Stafford. Dr. Stafford is a professor of medicine at the Stanford School of Medicine and the director of the program on prevention outcomes and practices. Dr. Stafford is a primary care physician in the Stanford Internal Medicine Clinic, where he focuses on chronic disease prevention and treatment. He also serves on expert committees advising a diverse range of organizations, including the California Medicaid Program, the National Committee on Quality Assurance, the American Heart Association, and the American Journal of Preventive Medicine. Throughout the talk, please enter any questions in the Q&A box at the bottom of your screen, and at the end of the talk, Dr. Stafford will answer as many of those as possible. Over to you, Dr. Stafford.
Thank you so much, Elisa. So I'm very happy to be here and talking today about chronic disease. And, the main theme that I'm going to cover is this idea of combining medications, health behaviors, and self-care. Basically, this talk is a compilation of a couple of other talks I've given in the past, trying to put things together to give a very brief summary of how I think chronic disease care is changing and how patients can get more involved in their own care. So among the topics I'm going to be covering tonight, first of all, is some survival tools for thriving with chronic disease. And a lot of these have to do with how to interact with your clinician to get the most out of your doctor's visits. I'm also going to present some thinking about a new way of chronic disease management. We've thought about chronic disease management almost as a accessory to the main part of our healthcare system, but it's clear that now we're in this mode where chronic disease is what we are spending most of our money on. It is responsible for most of the complications that patients experience, and we really do need to think about it in a more modern way. I'm also going to introduce the idea of health behavior change as a treatment. That is, no longer thinking about health behavior change as something we do to prevent disease, but more a set of tools that we can use to actually treat disease. And I think this might sound like a semantic distinction, but I can assure you it's very important in terms of how patients experience chronic disease care and the contribution that clinicians can make. I'm going to go through some of the key health behaviors just to give you a little bit of an idea of what we're doing and to put this in the context of this idea of systemic inflammation. And what I'm advocating essentially is that we make more prominent a whole set of health behaviors which might be considered anti-inflammatory. So we'll talk about this, and then at the very end, we'll have hopefully some time for questions and answers. As was said earlier, please put your questions and answers into the Q&A tab on Zoom. So this is one way of looking at successful aging, that we have a percent of functioning here, and we have the lifespan here. Now, a usual pattern of aging is really to see this idea that we gain maximal function, and then at a relatively early age, we begin to lose that. And we gradually lose that until we die. One of the things that this kind of pattern suggests is that most of the things that we are dying from, and most of the things that are reducing our function along this pathway, are preventable. And that if we engage in successful aging, we can basically make this diagram a lot more square so that we maintain our function kind of until a very old age, and then we may quickly fade away at that point, but we've gained this entire region in here of good function. And I'd like to suggest that most of what we think of as diseases of aging are really diseases of chronic neglect. They are preventable things that our lifestyles determine. And that if we want to be successful in terms of aging, we need to be physically and mentally active. We need to have strong social networks. We need to have purpose and meaning in our lives. And we need to try to find those environments that support this healthy lifestyle. So as an introduction, I want to just say that we live and we function within a healthcare system that is far from ideal. There are many problems with how healthcare is organized, with how we can access healthcare. And in some ways, I wouldn't be giving you tips for successful doctor's visits if our system was working ideally. Having said that, I think there are many strategies that patients can use to be more successful in terms of the healthcare they receive and in terms of their interactions with doctors. And I say this with all, humility, that sometimes within the current system, it's difficult for me to function in a way that I would really like to. And I think the same goes for most of my colleagues, around the country. In terms of some of these tips, I just wanted to cover these briefly. And these are really part of a larger topic of patients getting more involved in their own care. So a couple of the things that I'd like to suggest can be useful is to bring a family member or a friend with you to your doctor's appointment to anticipate what the doctor's going to need to do their work successfully. Some of that means coming prepared to ask questions, and also sometimes learning some basic medical terms that are used for your condition, so that even if the doctor is talking in jargon, which really she shouldn't be, but if she does, at least you'll get a good idea of what's going on. I think it's also a really good idea to come to the doctor's visit with a written log of things you're measuring at home or observations you're measuring. These could be things like values of your blood sugar, your blood pressure, your heart rate, or it could be things like symptoms you're having from esophageal reflux, heartburn. Keeping this written log can really provide another piece of information that your doctor can use to provide the best treatment. I think it's also important to be open about sensitive topics that affect you. There's a lot of stigma in our health care system about revealing things about mental health issues or talking about sexual health, but these things are critical to the lives we live. And I want you to feel that adding this information into the dialogue with clinicians often can lead to better care. And then finally, to recognize that you can play a bigger role in your own healthcare, I think is a very important concept. And I'll get back to that a little bit more. So I wanted to make the point that language in healthcare is a really important feature of communication. And I'll just read the first couple of sentences here. Language is one of the many tools of medicine. Language can educate and inform, or confuse and mislead. Language can inspire or alienate, cherish or insult. So we know that language is a very important part of healthcare. It's how we communicate. And this can be for gathering information about you. This can be coming up with treatment plans for the work that you and your doctor are doing to try to make your situation better, or for counseling around various issues. So communication is always more than information exchange. And in fact, language and how we think about diseases can affect our health and can affect how we think. So one example I'd like to give is that, many times in the past, we've thought about menopause as requiring hormone replacement. The idea being, in some sense, that the woman is deficient of hormone after menopause, And naturally, the inclination is to think, well, if I'm missing something, how about if I get that back in my system through hormone replacement? It's a very different type of mindset to think about menopause as part of a natural progression of life, and to realize that women have a great deal of variability in terms of how they experience menopause. Now, these two examples, really demonstrate that how we label things and how we talk about things can have a big impact on the type of therapies we seek, but also can really affect how we think about ourselves. If we think about ourselves as being deficient in a particular hormone, we're not going to feel as good or as satisfied with our lives as if we see menopause, for instance, as a natural part of the aging process where different women are going to have different experiences. And I think our healthcare system is moving towards recognizing some of these issues. We are starting to think about how communication really affects healthcare and health outcomes, but I think we're only part of the way there at this point. I wanted to shift and talk a little bit about how we often think about chronic disease management. And in a kind of idealized way, much thinking about chronic disease has kind of been taken this form here, that, we have general advice that we can give the public, and that we know that we should be physically active. We know some things about what constitutes a good diet. We know that we should sleep better than we do. These are sort of things that happen in a way outside the doctor's office. And then inside doctors' offices, we often adopt more intensive strategies around health behavior that are patient-specific. So I may tell a patient, well, I really need you to work on your weight and your intake of simple carbohydrates. But at some point, for many health conditions, we reach a point where the person needs drug therapy. And in general, this transition between the intensive health behavior strategies and drug therapies is such that we abandon the health behavior approaches, and we basically say, well, I need a drug, so now I don't have to worry about the health behaviors. And I think this type of approach actually is quite damaging in terms of alienating patients, but also losing the potential benefits of combining intensive health behavior change with drug therapy. So let's, for instance, think about how this might be approached differently. I think the idea is that, all consumers should be getting general advice about health behaviors. These intensive approaches can be added as needed in the clinician's office, and that added still are drug therapies with ongoing health behavior strategies. And just to give this, a little bit more concrete detail, let's think about cholesterol management. So we have general dietary advice, particularly from the U.S. Department of Agriculture. In the office, we often provide intensive dietary counseling, sometimes with a nutritionist. And then finally, often when we feel like this has failed, we move to prescribing a drug like statins. And in a more idealized world, we would sort of stack these different approaches one on top of each other, so that even when we embark on drug therapies, we are still wedded to the idea that health behavior change is needed, and that more general advice still should be heeded by the patient. I've heard many of my patients say things, for instance, such as, well, now that I'm on a statin, I can eat anything I want. And I think our approach has really created that sort of mentality, which really works against good health. I also want to make the point that we often treat these different chronic diseases, and here I've listed 4 of them for illustration, we often treat these very much in isolation from one another. So we think about high blood pressure, we think about high cholesterol, diabetes, fatty liver disease, often very separately. And in fact, we even have specialists to deal with each one of these rather than kind of trying to put them together and to get the synergy out of prevention strategies. So if this is the current state of affairs, what I'd like to suggest is that we could move towards something that's more like this, that we have a general health approach, public health approach to risk factors, covering these sort of things for the whole population, with more intensive behavior strategies as needed. And then for all of those patients, depending on their conditions, we add these therapies so that we're really consolidating the delivery of both the general prevention messages as well as these more intensive behavior change strategies. So what's different? Well, first of all, I want to suggest that we're seeing health behavior change as a treatment. We're no longer seeing it just as something we need to do to prevent chronic disease. And one can see this change in the guidelines around high blood pressure treatment that were released in 2017. The idea is that blood pressure should first be treated with these health behavior changes, and then only as needed, drugs added to this. I think we know that continued health behavior change is important even when drugs are added. And in fact, many drugs work better if they're combined with continuation of those same behavior changes. So that would be the case for statins. It's the case for most medications that work to lower blood pressure. And as I said before, we really want to consolidate health behavior change because essentially the same strategies or very similar strategies can be applied for multiple conditions. That is, physical activity, for instance, has these broad effects over a whole array of chronic conditions. And we ought to be using that synergy to get better outcomes. And of course, some of the health behaviors interact with one another, so that if I'm physically active and watching my diet, it's probably going to be easier for me to embark on weight loss. Or if I'm sleeping better, it's probably going to be easier for me to control my diet. So there's numerous ways in which we ought to combine these health behaviors and see them as really important treatments for these risk factors such as high blood pressure or diabetes. We also need to recognize that quite often non-physicians may be the ones who are best suited to facilitate behavior change. In many ways, our healthcare system is still very much oriented towards training doctors to deal with acute problems. And yet most of the conditions, most of the work of the healthcare system really revolves around trying to change the outcomes of these chronic conditions, such as high blood pressure, fatty liver, high cholesterol, or diabetes. And one important reason why these different types of health behavior change seem to affect multiple diseases is this idea of systemic inflammation. And what we're talking about here is chronic sustained activation of our immune systems or portions of our immune systems. And the idea that multiple health behaviors and mental processes even can modulate systemic inflammation. So there are a bunch of things that downregulate inflammation, that is, that they lessen inflammation. And these include things like physical activity, sleep, social interaction, fruits and vegetables in the diet, weight loss, relaxation strategies such as meditation. And then we know of kind of the corresponding behaviors that upregulate inflammation. That is, they make inflammation worse. And these include things like sedentary behavior, sleep deprivation, social isolation, processed carbohydrates in our diet, saturated and trans fats in our diet, as well as things like weight gain and social and psychological stress. So we now know, even though our knowledge of inflammation is still rudimentary, we know that inflammation is intimately tied to disease development. And this goes across a whole array of conditions, including atherosclerosis, the main cause of heart disease, cancer, cognitive decline, diabetes, and also depression and anxiety. So I want to point out that inflammation really is a key mediator here. And, we might look at it this way. I know this is a little bit complicated, but the idea is that we have these health behaviors that are occurring within an environment, and we have a certain predisposition genetically. But these biological mechanisms, such as inflammation, go a long ways towards creating these risk factors or these conditions that I've just been talking about, and then go on to create these disease outcomes. And of course, these are the things that people die of. And we know that these risk factors increase the risk of these diseases. And it may well be that these health behaviors create disease through increased inflammation, as well as these other biological mechanisms. I do want to say that whenever I talk about behavior change and the different risk factors, it's very easy to sort of think, well, he just doesn't know what he's talking about because it's not that easy. And I do want to admit that, none of these behavior changes that I'm suggesting as potential treatments for chronic disease are easy. And in fact, we know that there are a whole series of stages of change that people go through when they're trying to create change in their lives. And this kind of model applies whether it's becoming more physically active, getting a better night's sleep, being more socially networked, or trying to change one's diet. And this cycle starts with pre-contemplation, moves to contemplation, where we're thinking about what we want. We prepare for an action. We actually take the action, and then we have a process of trying to maintain where we are, sometimes lapsing or relapsing, and then needing to start over. So a couple of implications. First of all, this is a very complex process. It's nothing like reaching out and turning the switch for the light on in a room. It also involves these multiple steps before we even get to starting to act. So in other words, there is a lot of mental work that goes on before reaching this point where we're ready to take action. And also, the implication here is that relapse, in some ways, is a natural part of the process. And I know a lot of patients are often very disappointed when they have a lapse, when they go off of their diet, when they lose the momentum of being physically active. But one thing to keep in mind is that's a very natural part of this process, and people shouldn't necessarily beat themselves up for falling off the wagon. And the important thing to do is to get back on the cycle of behavior change. I also want to make the point that quite often the sort of skills and the sort of effort it takes to take action is quite different than the set of skills needed for maintaining. So that in many instances, taking action, getting started on a new diet, getting started on a new routine around sleep or physical activity is actually easier than the process of maintaining those same behaviors over time. And then along the lines of kind of behavior change, I just wanted to make a plea to kind of have you all be more in tune with what you're able to attain. And I like this idea of a SMART goal. It's a goal that's very specific, that you can measure, that you know is achievable or attainable, that it's realistic, and you can do it within a certain time frame. So I think this is a good set of hints when it comes to trying to motivate ourselves around a certain goal. And of course, January is the time when a lot of people set out to do things to change their behavior. Quite often, they don't follow these sort of dictates and take on more than they really can achieve. And I want to make the point that small steps forward are often much more effective than trying to take on a large goal that's not attainable. So I wanted to just go through some of the key risk factors. Most of you know this already, and I don't want to belabor these, but I just want to move through these in a way that gives you a little bit of an idea of why these are important. So maintaining a healthy body weight, which for most people is going to be a body mass index between 19 and 25, a little bit lower for people who are of East or South Asian descent. And there are substantial benefits of even a small amount of body weight loss. In other words, suggesting that there's really no reason to have a goal for weight loss that returns you to, let's say, how you were at age 20. Even a 5% loss of body weight can be enormously beneficial. And then there's also particular benefits of redistributing weight. The weight that we have in our abdomen within the belly is sort of the worst type of weight to have. And if we can convert some of that to muscle, or even just lose it completely, we can redistribute the weight and the fat within our bodies. Now, in terms of diet, there's a lot of confusion out there of what's a good diet. But I think all of the recommended diets, even many of the fad diets, have in common a number of things. First is that they're generally high in fruits, vegetables, and whole grains, that they try to reduce saturated and trans fats, that we would like to avoid sugar-sweetened beverages, and that we want a diet that's plant predominant and high in dietary fiber. We also want to move in the direction of a less processed diet that relies less on packaged foods. And then finally, some of these dietary approaches have been put into various types of diets that are recommended, including the DASH diet and variations on the Mediterranean diet. So again, these are important things that we ought to be incorporating within our lives, not only as prevention tools, but actually as treatment for chronic disease. In terms of physical activity, I think one of the messages over the last couple decades is that it's no longer enough to do aerobic physical activity. Yes, it's important that we do that with large muscle groups getting involved, with our heart rate increasing, and doing this, at least 150 minutes per week. But it is equally important to focus on strength training, where we are actually having moving our bodies against resistance. This may be particularly important for bone health and falls prevention as we get older. And then we also need a different type of exercise that really is isometric, that challenges us to balance and that trains our core muscles to really support our whole bodies. Many of these types of exercise involve muscle contraction as we hold the same position. And yoga is the perfect sort of demonstration of all of these things in one type of exercise where we are isometrically contracting muscles, we need our balance, and we are training our core. So I think there's a lot to be said for physical activity. I'm covering it so briefly here, I can almost not stand it. But physical activity is really one of the key things we need to do better to treat chronic disease. And then sleep is something that we haven't necessarily always emphasized, at least in my primary care practice. But it is important to know that both the quantity of sleep and the quality of sleep are potent anti-inflammatory strategies. This usually means about 7 hours of sleep without major interruptions, although this can vary person to person. It's really important to develop sleep routines and actually take seriously the idea that how we sleep does affect our health. Physical activity during the day can sometimes help with sleep, one of those interactions between different types of health behaviors. Usually recommended no screens at night. Having a screen, whether it's a phone or a TV, often is activating and makes it less easy for us to fall asleep. Limit naps during the day and try to avoid caffeine after noon. Limit alcohol use as well. We know that caffeine and alcohol use can interfere with sleep. Alcohol often makes people tired and sleepy, but the problem is the duration of sleep is usually more limited when we have alcohol on board. Substance use. So, this is kind of part and parcel of modern American society. And, in general, my feeling is less is better. But I think we can be mindful of the evidence out there in terms of what we're choosing. So, at one extreme are tobacco products, where we know that smoking is really the most potent risk factor for both heart disease and cancer. But we also have these new forms of smoking, including vaping, which probably are ultimately less harmful, at least to adults. The problem I see with vaping is that often it is a gateway to cigarette consumption later on after people have left their adolescence. Marijuana and THC products are out there, they're legal. The evidence of benefit is probably more sketchy than we think sometimes. And I'm still waiting for sort of more data to come about, not only for things like THC, but also other cannabinoids such as CBD. Now, coffee and tea has a drug called caffeine in it. In some sense, it is another substance, but likely has minimal downside, particularly compared to all of these other products and to substances that are used illicitly. One issue that I want to talk about is that in some ways, we're going through a shift in societal norms around alcohol that reminds me a lot of tobacco in the 1960s and 1970s. For so long, we have basically told ourselves that alcohol is good for us in small amounts. And it's probably not true. We've probably, in some sense, been fed a little bit of a mythology by the alcohol industry. So, alcohol is a liver toxin that does increase inflammation. It's also synergistic with other causes of inflammation. So for instance, the likelihood of esophageal cancer is much higher in people who both drink and smoke together. Probably the greatest harm of alcohol is from binging and high intake of alcohol, but there really is no safe daily exposure level. And in some ways, I liken this to something as simple as driving an automobile. Whenever you're in an automobile, there are dangers of accidents. There's the likelihood that at some point you may have an accident. The more you drive, the greater that risk. Alcohol in some ways is the same way. The likely range for minimal alcohol use is probably down as far as half a drink a day. So the idea that, we ought to be able to drink 1 or 2 drinks a day, that may be more than is actually healthy for us. And as I said, I think there's a lot of benefits. There's a lot of mythology about alcohol's benefits. Part of that is that there is a known benefit on lipids, the cholesterol, and cardiovascular disease. But those benefits are so far offset by other harms. So I wanted to illustrate a little bit of this. This is a chart showing the risk of developing cirrhosis of the liver, scarring of the liver. And this is the dose per day of alcohol. And, 1 drink per day is right around here at 14 grams per day. I'm going to focus in on this area down in the left bottom corner, just to illustrate something, which is that at a value of 1, the only use of alcohol that doesn't exceed that's neutral or potentially beneficial is down at this level of about 7 to 5 to 7 grams of alcohol per day. In other words, that half a drink I was talking about. You can see here that these are for people of different waist hip ratios. That is, the people who are the most obese had the greatest risk, and the greatest risk for even small amounts of alcohol, whereas those who were lighter and had less obesity, they had a slower increase in risk, but pretty much every single ounce, every single gram per day increased the risk associated with alcohol. So that's all I have to say. I think we have quite a bit of time for questions and answers. I see that we have a couple of questions coming in now, and I did get a list of questions that were elicited ahead of the schedule today. So I can start out by saying that DM is diabetes mellitus. This is the technical name for diabetes. And most of the time, we're most interested in talking about type 2 diabetes, which is the type of diabetes that affects people as adults that is associated with things like increased weight and sedentary lifestyle. There was also a question in the elicited ahead of time about how often blood pressure needs to be checked. So my general strategy here is first of all to recognize that 1 blood pressure doesn't necessarily mean very much. What's really important to know is that the body is designed, in a sense, to have blood pressure vary considerably during the day, and if in the event of certain things happening. So when we are physically active, our blood pressure rises. And when we're stressed out, our blood pressure rises. At other times, being calmer can lower blood pressure. So to really get an idea of how one's blood pressure is faring overall, we really need a series of checks of blood pressure. And this is important if we're diagnosing high blood pressure, or if we are changing are strategies around how to manage high blood pressure. In these sort of instances, I generally recommend, 3 to 4 times a week of measuring blood pressure at different times during the day. I also see another question about blood pressure here. What level of blood pressure is safe? So this is a topic of some debate within the medical community. The guidelines that I mentioned earlier, which came out in 2017 from the American Heart Association, as well as a large array of other professional organizations, basically states that normal blood pressure is anything below 120 over 80, and that we regard a blood pressure above 130 over 80 as generally higher than it should be. Now, there's a distinction between those people who are at low risk of things like heart attacks or stroke and those people who are at higher risk. For the people at low risk, which would include many younger women, for instance, it may be perfectly fine to have a level of blood pressure in the range under 140 over 90. But for somebody who has a high risk of heart disease or already has heart disease, a much lower blood pressure is desirable. So in other words, if I've had a past heart attack, I should have my blood pressure managed to below 130 over 80. There's a question also about continuous glucose monitoring. This is a new device. Well, not so new, but its use in type 2 diabetes is relatively new. This is a device that goes right underneath the skin with a little catheter and can essentially measure the minute-to-minute changes in blood sugar in our bodies. It may have a role for people with type 2 diabetes, especially if they're having difficulty controlling their blood sugar with insulin. Insulin has the unfortunate capability of both lowering blood sugar into the normal range, but it can also at times lower blood pressure below normal. And continuous glucose monitoring may be a really effective tool to manage blood sugar in those people that have the problem of too low and too high blood sugars. So you have a couple of other questions here. So one interesting part of this discussion of chronic inflammation is that we do have these drugs out there that are anti-inflammatory. And the name of the drug class for ibuprofen or Advil, these are a non-steroidal anti-inflammatory drug. Now, that doesn't necessarily mean that those drugs are capable of reversing the sort of inflammation that comes about because of diet, sedentary physical behavior, poor diet, little sleep, and stress. But it does affect part of the immune system, but not necessarily the part of the immune system that is causing the problems with chronic disease. So what this means is that in general, something like ibuprofen is not going to be effective in reversing the immune activation that is going to lead to, let's say, heart attacks. And in fact, there's some evidence that some types of non-steroidal anti-inflammatory drugs actually may promote heart disease. Yeah, and I just, along with one of the listeners, I just wanted to emphasize this idea that all of these different health behaviors really are how we live our lives. And the idea is to try to move in the direction of less pro-inflammatory behaviors and move in the direction of those behaviors that are going to reduce inflammation in our body. Now, there's a lot going on in terms of genetics, in terms of the sort of environments we live in. So I want to make it clear that you can be doing exactly the right thing and still develop high blood pressure and still have these outcomes of, let's say, heart disease, because not everyone is built the same and not everyone lives in an environment that facilitates, the sort of healthy outcomes that we all want. And so I think it's important just to recognize that this is not a reason to sort of to take people to task because they have developed chronic disease. There's a question about turmeric. And, this is an area of research. At this point, I am not entirely convinced that the evidence out there is enough to recommend turmeric as an anti-inflammatory. But clearly, there are compounds out there that often we have eaten as food, which may have an anti-inflammatory role. From my point of view, we're not really at the point where we have solid enough evidence to recommend something like turmeric intake. And yes, there's a question about blood pressure and the idea that there are multiple things that affect blood pressure. Getting older is associated with increased blood pressure. And part of the goal for many of us is to try to control blood pressure that would naturally rise because of aging. It's also true that increased weight is associated with higher blood pressure. Increased intake of salt is associated with greater blood pressure, and increased intake of alcohol as well. Keep those questions coming. I would. There's a question about fermented foods such as kimchi, and I think that there's still not enough evidence to be certain of the benefits. But it's clear that certain foods like kimchi, which are high in fiber and come from vegetable sources, are clearly better than many of the alternatives to kimchi. So, one of the issues with thinking about how diet affects our health is that diet is about not only what we eat and the effect of what we eat, but also what we eat in some ways excludes other foods that we don't eat. And it can be that the effects of a particular diet on health may be as much about what that diet tells us to avoid, as well as what that diet tells us to emphasize in our eating patterns. There's a really interesting comment here about this new class of diabetes drugs, which are called SLP1 inhibitors. And the drug that's gotten a lot of press recently is Ozempic. And this is an injectable drug that can be injected as far apart as every week, and essentially causes a reversal in some of the body's metabolism that would otherwise lead to bad control in diabetes or the development of diabetes, and in fact does promote weight loss. This drug has been such a fad drug, in fact, that many pharmacies have run low on their supplies of this drug. So what to say about this? So, first of all, this is an incredibly expensive drug. We're talking several $1,000s per year to be on this drug. And it probably does not have a effect that continues after you stop it. So most people who use these drugs do regain weight if they have to stop the drug. The other thing is that there's a certain way in which this reminds me a lot of the fen-phen disaster that I lived through in the 1990s, where two drugs, fenfluramine and phentermine, were used together for weight loss. And that turned out to have some major problems associated with it. Now, this may be a little bit different because these drugs have been through the FDA approval process for weight loss. So there is more data out there suggesting that they're safe, but I'm just not completely sure of the, kind of the overall net benefit of these drugs versus other strategies for weight loss. Clearly, this isn't an easy way to do it, but it's also an expensive and temporary way to obtain weight loss. But it's a great question, and you've prompted me to want to think about that a little bit more. There's a really interesting question about the similarities between physical and mental chronic conditions and their interaction. So I want to start out by saying that, we often don't talk about these mind-body interactions when it comes to chronic disease, but we should. And the fact is that our mental health and even our way of thinking about things can have a big impact on our physical health. Now, one connection between physical health and mental health is that many of these same pro-inflammatory types of behaviors make people more likely to develop depression and anxiety. And then at the same time, as I think you can imagine, that being depressed or being anxious often gets in the way of other types of behaviors or behavior change that could be good from a physical point of view. So, depression tends to be associated with more isolation and less activity. And that's a hard thing on our bodies in terms of not getting the physical activity, perhaps not eating as well. But at the heart, I think there's also this idea that we need to stop thinking about our bodies and minds so separately and realize that, we are in some sense a mind-body organism, and that we ought to take care of our mental health and our mindset just as much as we do our physical selves, and that these two are inextricably bound to one another. So I really appreciate that question, and I think it's something that our current healthcare system still has a long way to go in terms of in terms of that integration. So a question here about diabetes. And the question here is, to what extent is diabetes a potentially reversible problem? And the fact is that particularly early on after the diagnosis of diabetes, it is quite possible to reverse the metabolic changes that create diabetes. And some of this has to do with the fact that diabetes is really part of a continuum of insulin resistance, where our body becomes more and more prone to need more insulin to cause us to get rid of blood sugar that's circulating in our bloodstream. So that in the early part of insulin resistance, somebody might be called pre-diabetic. Whereas if that process of insulin resistance progresses and continues to get worse, diabetes will result. And the main sort of culprits around insulin resistance, the number one is body weight, and particularly weight within the abdominal cavity or fat within the abdominal cavity. But things like lack of physical activity, a diet that's high in simple carbohydrates, and diets that have trans or a lot of saturated fats also can make people prone to insulin resistance. So in some sense, we can reverse diabetes if it's done early. And I think this is a really good example of how treatment with health behavior changes in some ways can be just as good as medication treatments in this range of people who are either pre-diabetic, that is not quite up to diabetes, or their blood sugar has gone up high enough so that they are just newly classified as having diabetes. And I do want to say that, although diabetes causes a great number of complications, such as kidney disease, eye disease, damage to the nerves, heart disease, some of those same impacts are present for prediabetes, but just not at the same magnitude as when blood sugar rises and diabetes is diagnosed. So there's a question also about vegetarian and plant-based diets. And in general, yes, plant-based diets can have a benefit in terms of controlling cholesterol and can reduce inflammation. But it's also important to recognize that you can take any kind of dietary restrictions or dietary emphasis and change it in such a way that it becomes unhealthy. So to the extent that a vegetarian diet is mostly unprocessed plants, whole grains, and fruits, that's going to be a diet that has benefits. On the other hand, it's easy to eat a vegetarian diet that's still quite high in processed carbohydrates, things like flour or sugars. Again, vegetarian, they come from plants, but it's not necessarily a great diet. So it's not enough just to say vegetarian or plant-based, but it really has to do with eating foods that are complex, that take our bodies a while to digest, and don't have the sudden influx of nutrients into our body that often comes when we consume things like white rice, white bread, or sugar. Just going back a little bit here. Well, one question that came up was, again, a couple questions about different dietary supplements. One that's very interesting is coenzyme Q10. There is some evidence that this supplement may help people tolerate statins more easily. There is although most people have no reaction to statins, there is a subset of the population that gets muscle aching and joint aching with statins. And it has been found that for some of these people, taking coenzyme Q10 can help them tolerate statins better than they would otherwise. So let me see if there's any last things here. Just a question about caffeine and high blood pressure. Generally the amount that caffeine makes the difference in blood pressure is not very significant. But caffeine in very large doses can make people quite anxious. And it's that anxiety that often will raise people's blood pressure. So it's one of those things I think you have to you be mindful of to consume things in moderation. So I think that we're going to wind up for today. I really appreciate your attention and all the questions you've been throwing at me. I think that the goal today is to really introduce you to some new ways of thinking about chronic disease and hopefully allow you to take a bigger role in your own healthcare. And in some sense, the great thing about this approach that emphasizes health behaviors is that these are your opportunity to really treat and to manage the chronic conditions you have. You don't necessarily have to be fully dependent on the healthcare system to be able to do the right thing.
Thank you, Dr. Stafford, for sharing all that great information. And thank you to our audience for joining us and for all those great questions. If you'd like additional information or resources, please reach out to us at the Stanford Health Library, and we hope that you'll join us at our next lecture. Goodbye.